Welcome to this clinical walkthrough on an implosive paracetamol overdose case for UKMLA, brought to you by Mediate, your 24/7 practice partner. All right, in this explainer, we're going to break down exactly how you can nail this classic OSCE station. Think of it as a clear roadmap to follow. We'll go through 4 key stages. First, understanding the scenario you're given, then asking all the right questions. After that, we'll form your management plan, and finally, we'll cover how to advise and refer safely. Ready? Let's get into it. Okay, let's dive right in. First up, understanding the scenario. This is the snapshot of information you'll get on the door, right before you walk into the room. So, here's what you're working with. You're about to see a 20-year-old man. He's taken 20 paracetamol tablets about 2 hours ago, and it happened right after an argument with his mother. Your job? Walk in there, build that all-important rapport, confirm these key details, and then, start digging a little deeper to get the full story. Okay, this next part is maybe the most important bit of your initial chat with the patient, asking the right questions. Your history taking is what builds your entire medical and psychiatric risk assessment. So what are those key questions you absolutely have to ask? Let's break them down. First things first, you've got to start with the basics. And remember, your tone here is key, calm, non-judgmental. You just ask, how many tablets did you take and when exactly? This does 2 things. It confirms that core info you were given, and it locks down the timeline. And that timeline, well, that's the foundation for your entire medical plan. So, the patient confirms it. 20 tablets, 2 hours ago. Now, this timing is super critical. You have to remember, we can't accurately check paracetamol levels until at least 4 hours have passed. Why? Because that's when the drug concentration in the blood actually peaks. Any earlier, and you might get a falsely reassuring result. All right, next up, you need to get the backstory, the context. A really powerful way to do this is with an open-ended question like, what led to this? It's simple, but it's great because it lets the patient tell you their story in their own words. And that's how you start building that trust, that rapport, which is so important in a sensitive situation like this. And he'll tell you that he had an argument with his mother right after disclosing his sexual orientation. Now, this is a vital piece of the puzzle. It's not just about building empathy with your patient, it also gives the psychiatric team some really critical context about the huge social stressor that triggered this whole thing. This next question is a huge one for figuring out the level of risk. You've got to ask, did you plan this or was it on impulse? Their answer here is absolutely key. It helps you figure out the level of suicidal intent and will pretty much shape your entire assessment of how safe they are right now. He says it was impulsive, and that's a really important distinction to make. Look, an impulsive act is still incredibly serious, don't get me wrong, but it often points to a lower ongoing risk than a carefully planned attempt. It suggests this was a reaction to a momentary crisis, not a long-term plan. Here's another great question, and this one helps you find what we call protective factors. Simply asking, what made you decide to come to the hospital? It's a great way to understand their mindset after the event and to see what kind of support systems they might have. So he tells you he called his boyfriend, and his boyfriend told him to get help. And that right there is the crucial part. He reached out. That simple act shows insight, it shows a desire to live. These are massive positive factors you need to note in your assessment. Okay, so we've gathered all this info. Now what? Let's move on and see how it all comes together to build your management plan. You've done the history-taking part. Now it's time to turn that into a clear, safe plan of action. So let's just quickly summarize what we've got. We're looking at a lower-risk scenario here. Why? Well, because the act was impulsive, not planned. He called for help right away. He doesn't have any history of self-harm, and he's telling you he regrets what he did. See how all those questions we asked feed directly into this assessment? Now, for the medical side of things, it follows a really strict pathway. You can't deviate from this. Step 1, you have to wait until at least 4 hours have passed since you took the tablets. Step 2, you take a blood test to check his paracetamol level. And step 3, if that level is high, above the treatment line, you'll start the antidote, N-acetylcysteine, or NAC for short. And you've got to explain this waiting period to your patient, right? Keep it simple. You can say something just like this. We need to wait a bit longer before we do the blood test, just to see how your body is processing the tablets. If we do it too early, we could get a false result, and we don't want that. So that blood result is going to dictate what happens next, and there are 2 paths. Path 1. The paracetamol level is high. You start the NAC treatment, and after that's done, you refer to psych. Path 2. The level is low. Phew, no NAC needed. But, and this is a big but, you still have to refer him to the psychiatric liaison team before he can even think about being discharged. See the common thread? No matter what the bloods say, a psych assessment is absolutely mandatory. Getting these two pathways straight in your head is so important. And hey, if you want to test yourself and see if you can handle this exact scenario under a bit of pressure, you can practice this exact case right now, get objective feedback on mymediate.com. All right, we're on the home stretch now. Let's talk about the final piece of the puzzle, which is super important. Advising and referring safely. You know, how you talk about the plan is often just as important as the plan itself. You have to give some really clear health advice here. A great phrase to use is something like, even though this dose might not cause serious harm this time, it's important you know that any overdose carries a risk to the liver. See how that's educational, not preachy? That's the tone you want. And for safety netting, this next one is a must-say. You need to clearly state, just because you feel okay right now doesn't mean the outcome will always be the same in the future. It's a direct, clear warning against taking this risk again. Let's be crystal clear about the psychiatric plan. The rule is simple. Every patient who comes in after a deliberate overdose must be seen by the psychiatric liaison team. This is totally non-negotiable. Why? Because the medical issue is just one part of it. We have to address the underlying distress that led to the overdose in the first place, or we're not doing our job to prevent it from happening again. And of course, how you bring this up makes all the difference. You want to frame it as support, not a punishment. Say something warm and empathetic like, this was clearly a really tough moment for you, but we're going to make sure you don't have to deal with it alone. I'm going to ask my colleagues from our psychiatric support team to come and have a chat with you. It sounds so much better, right? So if you follow this structured approach, you're going to feel so much more confident and safe in this OSCE station. To put all this theory into action, you can practice this exact case now on mymediate.com. Go give it a try. Good luck.